So, really excited to welcome Clem Foltz to our podcast for this week. Clem is an actuary colleague that I've gotten to know and collaborate with on various initiatives. He's an expert in specialty value-based care, among other things. So, thank you, Clem, for joining us. And I think what I'd love to kick it off with is just hearing a little about your actuary story and your background, and where you've been in your work travels to date.
Thanks, Eric. Yeah, Clem Foltz. So, actuary by training. I started out at Aon right out of college, and then I'm in Minnesota, so I transferred to and spent my time at Optum and United Health Group, some formative years there, especially within Optum Health, which is their value-based care portion of the business, and really getting to see kind of the way that a large organization like Optum Health thinks about value-based care and managing care through their providers. And then transitioned more recently to working with a variety of healthcare ventures and stages of companies. And so most recently I've been working independently supporting a variety of organizations.
Awesome. And tell me a little bit, I don't know the path personally, but like how does one become an actuary and like what school and training is required or test to do that? Because I actually have not the fullest understanding of that.
Yeah, you're not alone on that one. There's it's a really interesting and niche. So there's about like 25,000 actuaries total in North America. So it's not a large profession. I kind of fell into it. I went to St. Thomas here, which is located in the Twin Cities, and I had a professor there. So I came in wanting to study, I think I wanted to do something science related. So, even though actuarial science has science in the name, I wanted to do chemistry, biology. I think I was thinking something around medical. Um, and I found out really quickly, A, I really don't like blood. I don't do well with blood. And then B, those lab classes, it would be like a beautiful day in Minnesota here. And they'd have a 3 hour lab where I had to like titrate bases for 3 hours. And I lost my patience with that. And so at the same time, I was taking a class my freshman year. And I found out after the fact that the lady who runs the actuarial program, she would teach a freshman calculus class with the idea of trying to recruit students into the actuarial science program. And so she was kind of like a grandmothery type figure. And, I really like connected with her, and she was like, come talk to me about actuarial science. And so I turned her down like 2 or 3 times, but then finally I came up to her office and she like laid out this vision of like, you graduate from school, you don't have to go on to a master's degree, and then you start working and studying and taking exams at the same time. And it's a pretty defined study for exams, pass exams, and every time you pass an exam you get a pay raise, and after you pass the first set of exams you become an associate of the Society of Actuaries, and then after you finish the next set of exams you can become a fellow. That's kind of the top level actuary. And so it's usually ASA is about 5 exams. They've now expanded it, so you have to write some papers and do some coding modules and things like that. FSA is like another 3 or 4 exams with some more modules and papers. There's usually some professionalism. All told, it usually takes 6 to 10 years to kind of get through them. So each of those exams is usually a couple hundred hours of studying per exam, and they're usually really focused on specific topics. Like, I think the first one that I did was probability, and then you do theory of interest, and then kind of work your way up from there. And the base module, the base exams are more generic kind of for all actuaries, and then as you get more targeted in your profession, they'll have deeper dive exams in specific industry questions.
So obviously healthcare is probably one. What are the different buckets of actuarial specialties?
Yeah, so there is life insurance, health insurance. Those are kind of two easy ones, and then there's property casualty. So think, stuff and things, cars and things like that. And then you also have pension and retirement savings. So those are really the four. They've kind of added some new ones recently where you can do things like some financial engineering, but really the core of it is actuaries are usually employed in one of those kind of four main fields.
And so what majors do you have to do in college to be, is there a
There's
set?
Yeah, there's really no requirement to being an actuary. So I've worked with people who were math majors and they started out in teaching and then transition. I've also worked with people who had like a theater major or a music major and never actually took math classes. And so, really, in order to join the Society of Actuaries, you just have to meet the requirements, which is pass these exams that they offer a few times a year and then do some professionalism and module writing. And so, what's interesting is if you go back 20, 30 years ago, a lot of the people I worked with out of college who are a little bit older, none of them, like, people don't know what actuarial science is. And so you had a lot of really diverse backgrounds, economics, or just, people were into something. And then you find the exams, you take the exams, and that's how you became an actuary. Nowadays, there's a lot of programs that are kind of custom built. So, it used to be uncommon for people to have passed very many of the exams before they graduated college. Nowadays, there's schools and programs, St. Thomas being one of them, where it's pretty common for people to graduate with 2 or 3 of the exams done or more. And so you can essentially be on your path to being an accredited actuary. The reason that you're accredited is like it varies in field to field, but within those, but really at the end of the day, when you become accredited actuary, you now have the ability to sign legal documents that would reflect back to the government to state, an actuarial opinion about, it's a legal contract essentially, and it varies in each of the fields. So, like in life insurance, you might have to sign off on the reserves. Hey, the amount of money we have today, so that in the event that the company goes under, the actuary had done their best job to kind of articulate that. And the reason it's such a that's just so important to make sure that the assets line up with the liabilities, and these liabilities are complicated, and so you have an actuary who would have to attest and sign off. What's interesting is um, the signing requirements are different, and nowadays, like, so for example, the team I was on at Optum, we had 200 actuaries. You really only needed one of them to sign the legal statement of opinion, and so the rest of us were just kind of working on a variety of topics. But in reality, it really is, depending on the field, the specific industry you're working in, and depending on the company, it is meant to be a, hey, I'm attesting that the company has sufficient reserves to cover this product, and I'm standing behind it. So there are situations where actuaries get sued because of that. So there's issues or interesting things that can kind of arise out of that.
Okay, I would have assumed that you would have had to have biostats college degree or whatever, but I mean, in medicine, like we have a pre-med curriculum. You have organic and you have regular chemistry and lab stuff and biology, and none of it really parlays into anything useful. So I think the way that the societies on the actuary side do it seem pretty
Yeah,
reasonable.
and I mean, I would say like our initial probability exams are kind of like that. You're not really utilizing that in any day-to-day work, but it's the foundational work. And the way that they kind of control for that is everyone has to take the same series of tests, basically.
Right.
And so you can approve it out through that.
And then so like if you're starting out, and this is kind of a side tangent
Yeah.
here. How do you get your first job if you haven't gotten certification? You have to wait to get a certification, do something else, get the certifications, a baseline, and then become an associate, and then get your first job.
No, you usually, again, because like you think about the way that like I mentioned how at Optum, we basically had one person signing for hundreds of employees, and so what often happens is you're kind of like almost an apprentice type model where you start working under people who are credentialed, you learn from them, and in fact, for a lot of things, you can't, even if you have the experience and you've passed the exams, you still can't sign off until you've worked under someone and it gotten, like there's different rules in place for different products, but like you have to have sufficient exposure and experience working with the intricacies of that product before you can actually legally sign off on it, or feel comfortable signing off on it. And so that process is, yeah, you're usually working under people who are credentialed and supporting them and kind of helping draft the work products. And so that's how you would gain that experience. And at this stage, almost any employer that employs actuary will have a dedicated exam program where they provide support, and that's what they're really looking to hire. So usually it's like you want to pass somewhere between 1 and 3 exams, and then you can get that first job. And then once you get a job, you'll keep passing exams, the company will pay for that, and you're kind of off to the races.
Awesome. Okay. So kind of switching gears back to health, you know, how did you kind of, I know you had a little bit of an interest in science on the health side. I think you told me you had some family members in medicine. So is that what kind of got you on the health track, or was something as you did your actuarial work that you're like, okay, this is the right track for me?
Right out of college, I did some work in the retirement field, and then pretty quickly was like, I think of medical, healthcare as kind of one of the biggest challenges facing our country right now. You can see the rate of increase in cost, how much money is being spent, and what we're getting for it. And so I was just extremely motivated to get into healthcare, thinking about that opportunity of, like, for me, it's a way to help people and help the system, while at the same time using the skills that I've built up as an actuary to try and do that, as opposed to maybe a more direct clinical way of supporting people.
It makes sense. And so, kind of segueing in, we obviously work with health plans and some larger employers, and most of them know from their own med econ teams that musculoskeletal costs are really high, and you know, for the plans that we work with or just folks that are trying to help the plans, how do you even begin to dissect? Okay, we got a lot of MSK costs. Like, what does that mean? Because MSK includes elective things like, hey, I want to get this rotator cuff fixed, meniscus fixed, whatever, and non-elective stuff like I have fractured my arm and it's sticking out of my skin. Like, how do you start to tease apart like, or hey, surgeon A does three times as many surgeries for the same condition as surgeon B, right? How do you tease apart some of those quality, elective, non-elective? How do you even begin from a high level to even think about addressing it?
Yeah, and that's the challenge with healthcare, right? I mean, the way I tend to think about it, and I think you'll hear this kind of repeated, but like especially with an MSK spend in particular, there's kind of like necessary spend. This is I don't you won't find pushback even from actuaries or people anywhere that's like that necessary spend bucket is things that we think are important to spend money on because they're driving better outcomes. The goal is not to suppress or kind of push down utilization for care that's needed. It's really about trying to get the right care at the right time. So that first bucket of spend that I think of, if you were to break it out, that's good. Like that's the spend that's getting people healthier, and you need that to happen. I think there's maybe two other buckets that are worth kind of exploring a little bit, which is there's also spend that is kind of like non-optimized or inefficient in terms of the pathway. So you know you think about someone and the way that they engage in the journey of getting their healthcare, and especially within the lens of uh, MSK. And I think this is where, Eric, I'd be curious to hear your experience with this. But from a claims perspective, you can start to see, okay, if this person got an MRI and saw this doctor, and then they go and they get an MRI and they see this doctor, and then they go in and get an MRI and they see this doctor, it's like clearly they're not engaging with the process. The process isn't working for that person. And so that to me is like opportunity and signaling that second bucket of spend is a situation where someone's not getting the right care at the right time. And you'll see that in the claims. I'm curious to see how you think about that as kind of like as a doctor. But maybe I'll give you the third bucket of spend quickly is like, now someone even gets the right, they get to the right doctor and they see that right care. What happens if that person doesn't actually get better from that situation? I think there's another bucket here where it turns out that getting care, it just didn't end up matching kind of the severity or the conditions, and so they're stuck either with reoccurring issues, or they got the surgery done but now they're having issues after surgery. And so to me, that kind of like you didn't get the right outcome. And so I guess I kind of would break it into those three buckets kind of at a high level. Now the tricky part is you can't, how do you actually break the claims into those three buckets? That's a whole nother conversation. But before we get into that, I guess I'm curious, Eric, how do you think about that from what you've seen on the clinical side?
Yeah, I think you hit on a couple things, right? One was on the concept of quality, right? Getting a surgery, not getting better. And historically, when we've looked at quality, there's two ways to look at quality. One's from an administrative kind of a claims perspective. The other is from a subjective perspective. The administrative claims perspective, and this is what CMS has historically done until now, really, is what's your readmission rate, surgical site infection rate, mortality rate. When you're going in for a knee replacement, those are not what you're thinking about. You know they're possible. You're educated that they're possible events, and like you certainly don't want to be in that bucket. But you're thinking about, is this going to improve my pain? Is it going, how long will it take me to improve my pain? Maybe what's the chance of having a bad outcome? What if I get worse? And that gets to patient reported outcomes measures, which is what
Mm-hmm.
obviously we've spoken a lot about, which is not captured in the claims, right? There's no way to collect that. So if you have a group that has a cohort that's getting a total knee replacement and they go to surgeon A, B, C, D, and E, there's no way to tell the payer side outside of administrative data that I mentioned if those
Yep.
surgeons are doing a good job, right? And so um, it's a huge problem, right? And it goes to a lot of limitations of trying to identify opportunities to improve care. The other thing you mentioned is like engagement on folks getting MRIs and then going to see physicians and surgeons. The biggest thing is that a lot of studies are showing that the biggest predictors of spend are getting that first X-ray or MRI.
Mm-hmm.
And guess what? As a payer, you are kind of out of luck if you're reacting to claims data on X-rays and MRIs because it already
Mhm.
happened. The cat is a little bit out of the bag. And that's where utilization management comes in and the abrasiveness that comes along with it. And there is a place for it, but by and large, I think everybody would agree that it is a very abrasive, high friction process. I have three requests or denials that I've got to go through for fairly straightforward procedures I'm doing in the next couple of weeks, and I've got to figure out how to schedule three appointments with different payers on it, and they're all going to be quickly overturned, but that's just the reality. So yeah, so I think, without getting too long-winded, that's the issue we have. And when you look at, like you said, like avoidable spend, we know that who you see, MSK, unlike a lot of the other conditions,
Yeah.
is uniquely modifiable, right? Like, so if you see me in the office, your chance of getting a surgery for the same condition is very different if you see somebody else in the office. So I think that's the situation we're dealing with.
And how you develop that story of what is the counterfactual here. If if this patient had seen this doctor versus this doctor, I think sometimes payers are busy with lots of different problems, but like from my perspective, there is a process that you can go through if you have enough data to kind of tease out some of that. But it isn't necessarily, it might be straightforward, but it still could take a lot of time and resources to kind of capture what I think of as like what's that variation between practices of doctors and practices in general, like two different
Yeah.
facilities, and which ones are maybe getting you quicker to an MRI versus which ones are doing more conservative care up front, and then how do you also educate the members around that to kind of, well, what should the member do if they, I mean, I can attest, I like to play sports, and so I've had an incident or two where, I was playing touch football with my friends and I, messed up my knee. And I was like, well, what do I do in this situation? And so it's like, it's on a personal level. It's like, how should you actually navigate getting the right care? It
Yeah, and we know that people want the most expensive care possible. There's studies that show they'd rather they paid for insurance, they got insurance, they want the expensive MRI, even if it's only 1% which is 1/6 the cost or whatever. And that's what there's a lot of entitlement there. And to your point, right? If it's your knee and you're like, an MRI is gonna be 1% more diagnostic, let's get the MRI, right? So
I think there should be guardrail. That one, it's interesting because it's like I've also heard, and I'm curious what your experience with this is. Some of the things that I anecdotally hear are things like, when you get that MRI, it's showing stuff that shows up on the MRI that you maybe not even noticed as pain, but now all of a sudden you're finding all these new issues. And it's kind of almost developing. I think that's where the MSK, the avoidable
yeah.
part, can come in. Is if we hadn't done the MRI, we wouldn't have found these other problems, and that might not have led down this, alternative path to surgery or even just to escalated care.
And so thinking from a health plan perspective, we know that MSK typically is a top 1 to 3 cost driver across the plan. At what point, like sometimes we'll hear a plan say, oh, MSK is number 4, so we're prioritizing it differently than someone who's number 6 or number 1.
Yep.
But also if something is the number 4 cost driver, number 1, 2, and 3 are not modifiable, like
Yep.
in extreme case, like car accidents and stuff like that, then you can't fix number 1 through 3. So how does a plan even think or get their head around, okay, is this something we can address, whether it's any specialty, right? MSK or not? Like, how do they look at this condition and say, okay, number 4 we can fix, number 1, 2, and 3 we can't, number 6 we can? How do you even start to think about that? We can use MSK as an example.
Sure. Yeah. And I mean, I think we'll use MSK as an example, but I think this type of thinking works for many conditions. So when I think about like, how are you going to measure the variation and the ability to impact this care? I usually think about it in a couple different like structures here. So the first thing is like, what's the sequence that I can see and observe in the claims data that this person's going through? So again, I'm thinking about this from the perspective of I'm the health plan. I've got this data. I need to analyze it to try and figure out what my opportunity might be. So I'm going to sequence it and say how many people, got a diagnosis and then had PT first, or got a diagnosis and then had an MRI first. What's that order of the sequence in which they're experiencing the care? And what's interesting is, again, there's going to be some sequences that I would think are preferable from a financial perspective. And also, like, what's the speed at which you are working through those? So the first one is what's the sequence that you're going through to kind of seek care or experience care in the system, and then how quickly or what's the time frame for that. So are you doing an MRI and then quickly getting PT afterwards? Are you getting that MRI and then going straight to a specialist? and getting escalated to surgery quickly. I think these are the ways that I would think about it. Is you're starting to kind of break out your claims data, and this is where, again, I think it's clear how you should think through it, but it's difficult in practice to work through your claims data, especially for actuaries or teams that are working with a lot of different problems. So you got that sequence part, you've got the timing part. You also want to start to capture like intensity of care. How many PT visits, how many MRIs, how many CT scans did we have done during this care journey for this member? And so what's interesting there is, I think, this won't be much of an insight, but you'll start to see clusters around like whatever your prior auth. If you require a certain number of PT visits before surgery, well, then you'll likely see a cluster of people that did that number of PT visits, which to me is like, you know, there's nothing probably magical about that number of PT visits that you chose, right? And so, you know, again, I'm curious. I see you smiling too, Eric. I'm curious what your experience was seeing that.
Yeah, the I'm just thinking to I couldn't even stop myself from smiling. The prior auth requests we get or the denials we get because we didn't document a weight loss counseling for someone's BMI over 30, a smoking cessation plan for someone who smokes, document that they did actually they said you'll get a denial and say, well, so and so didn't do physical therapy. So all you have to say in your note is they did an exercise program. So I'm just thinking about those things where it's like, okay, fine, we update the note and they're like, or recall them and say, you smoke, smoking's bad for you, higher risk for surgery, and then it gets approved. And just thinking about that administrative waste that's going
Yeah.
on. And, and again, we've talked about this in other podcast episodes on the UM side, where what UM forced us to do, or maybe scheduling forced us to do, is that if we're going to do a shoulder surgery, we may have to fix your rotator cuff. But if your biceps is torn, I got to fix your biceps. If there's debris, we have to do debridement. If there's bursitis, we have to do bursectomy. And what happened was we would say we'll do a rotator cuff and related procedures. And then in the on the approval side, we were told you got to list what you're going to do. Okay, fine. We're going to list 5 things that we could do, but I'm not going to touch the biceps if we don't go in there. Well, now UM is saying we're going to deny the biceps because the biceps is normal, and they're going to take credit for it. So the prior
Sure.
auth companies are taking credit for the biceps that they saved, which would never save. So I'm going to ask you a second question. We hear these terms like counterfactual, or is it real cost avoidance or delay of costs? Or, how do you prove it's real cost savings versus not? Like, how do you get around like the nomenclature for all that is? And then also like what should we be using? ROI, net, gross, cost savings, net, gross. Like how do we start to unbundle that kind of quagmire of terminology?
You asked such an easy question
Yeah.
so early
Two of
into
them.
this podcast. Yeah, no, I think it really, at the end of the day, you do just need to take a step back and think about this broadly. Like, you know, again, I've been a part of organizations where, yeah, our affordability team is saying that they're saving $1 billion of cost of care, but our trend is still also going up by a percentage that makes people uncomfortable. And so, how can both of those things be true at the same time? I think there's almost like a cottage industry here of like trying to create cost to then also avoid cost. And like what you're talking about, the I think it really gets back to, I was kind of walking through those principles of how do we measure, this specific care. It's, that sequence of variation, the timing, the intensity. I was going to mention like site of care, where are these sites of care occurring? And then the key thing that brings it all together is what are the outcomes? Because, at the end of the day, the healthcare payer is buying health outcomes. It doesn't always feel like that necessarily, but really what they're doing is they're buying a certain set of outcomes, healthier patients, things like that. And I don't know that, there are times when things like um, UM can help, adjust the cost at what you're purchasing for potentially, or, trying to deny inappropriate care. And I think has a purpose and has good intentions, but at the same time, what you're really trying to get at is just buying better outcomes for the money that you're spending. And I think that's where it's a little bit harder to put in place a program where you would actually step back and say, okay, rather than just doing the easy button of adding this over the top, we actually need to really go through this process of thinking about that sequence of care, the timing, the variation between our providers, how many of them are, escalating people probably prematurely. That's real difficult, time consuming, analytical supporting data work that you have to go through. And at the end of that, you can then say, like, I need to buy better results by directing the path of care this way. And to me, that's different, or offering alternative programs or pathways to kind of buy that outcome. That's different than what UM is trying to do, right? UM is trying to like overlay and be that easy button at the end, potentially. I'm maybe overgeneralizing or simplifying, but I guess I would kind of take that step back to say, you really need to kind of go deeper into what are the variations within my employee base, or my participants, and see how it's manifesting itself to try and buy better outcomes.
And then when you look at cost savings, you have to have some sort of comparison, right? So from my lay perspective, maybe a little less lay now that I've kind of dove into this a little bit, but you have options of randomized trials in the same market. You can compare similar type patients, whether it's from age, gender matched, risk matched in other markets.
Yep.
You could do a time based, like what was happening last year versus this year. But then you get in the topic of trends and stuff. So how do we set up, like let's say you do an intervention, how do we set up ways to actually see if it works? Like what are some of the broad principles on just understanding high level that part of things?
Yeah. So now you're talking like, how do we develop that right counterfactual? What is the believable cohort comparison? I think it's really important to first kind of decide on, well, what's the unit that we're trying to do this analysis on? Are we trying to, analyze episodes of care, which is kind of more that style that I was kind of laying out? Like, what is the beginning of the episode? What's the end of the episode? How are they kind of being treated during that care journey? Are we trying to look at, what's our member level MSK spend? And that would be made up of the utilization and the unit cost kind of together. And so you actually need to like think about the components and kind of the utilization and unit costs. Or are we trying to think about this from a total cost of care? So I think you kind of need to decide from the beginning, what's the right framework that we want to evaluate this on. I think there's pros and cons to each of those, but if we just generally take the member level MSK as a starting point, now we need to build that comparison group. You can't just choose the members who didn't engage with care or did engage with care. You get so much, I think we'll talk through the risk here in a second, but there's selection bias, mean reversion, things like that. It's really about trying to design a matched kind of population. And the stronger designs would say we want to match non-participants in this care pathway, this sequence of care, with similar members um, who took a different pathway. And that's really, and we want to make them as similar and possible as we possibly can. So I wouldn't want to compare one program that has a $0 copay for PT versus another
That's a
program
good
that is
point.
$50 copay. So
Yeah.
like within it, you want to control for employer benefit, geography. You want to think about the things that you can think about to control. Again, you're trying to think about what's going to impact that utilization and unit cost. Now we're trying to match on those factors. And then ideally, we would also do some baseline risk comparison. And, this could get as simple as doing a cost match. We're just going to match the cost. Or it could be more complicated where you're doing a risk based adjustment. You're matching specific prior utilization experience. Hey, we're going to look at just the people who had an MRI visit during this month or this period. We're going to compare them and their outcomes afterwards. And ideally, some of the things that I would think that you could add color on here from a medical perspective, you want to work with a medical person to say, the doctor to say, well, what are the clinical differences? Because you're really trying to tease out, is this difference in care due to the severity of the patient or due to the journey that they took through the system? And ideally, you're matching up similar levels of severity and then reviewing it that way. So I'll pause there and see what
No,
thoughts
that's
you
a
might
good
have.
point. So, again, from a clinical perspective, you think about risk adjustment, right? So on one hand, if somebody has bounced around the system and gotten a bunch of these different diagnoses, they're going to look more complex medically from an orthopedic perspective. They've got rotator cuff tear, rotator cuff tendonitis, bicep tendonitis. You get 6 or 7 diagnoses. It's going to look like a very complicated person that needs treatment for all of them. But it just could be different ways of saying their shoulder hurts. And we're just throwing diagnoses out. I don't know. It could be your biceps. It could be people confuse those things all the time. I see people with frozen shoulders and someone diagnosed them with bicep tendonitis. You get every diagnosis on the sun. The other way to risk assess, I guess, would be like you said, through medical factors, right? Like how many different diagnoses we have. This is where all the upcoding, downcoding stuff comes in. Um, then on cost of care, but I like how you talk about the utilization, right? So if you have a population of, let's say, let's say you're talking about MA. You know, MA is a little bit bimodal, right? You have the more active group and then the less active group as they get older. But like, let's say you look at 65 to 85-year-olds. I think there's a lot of merit in saying, okay, how many of them have baseline gotten an X-ray for their back pain, right? Or
Hmm.
X-ray for back pain, or a diagnosis for back pain, and then what happens to them? So based on
Yeah.
that history type trigger, because to me that seems like a very valid way. But what are the better ways to do risk assessment and adjustment for MSK?
Yeah, I'm actually thinking here some of the things that we could talk through would be actually, maybe we look at that initial diagnosis and say, look, these people both presented at early in the navigation process with a similar diagnosis on the front end. And then after that, they experienced different, this person went to a specialist next, and this person went into a PT program. And guess what? Even though they both had kind of showed initially the same sort of, similar looking from a claims perspective diagnosis, this person ended up getting surgery within 6 months, and this person did PT for a period of time. And, it's difficult to draw big conclusions from a small sample size there. And so you're really trying to like look and say, from a population level, are there systematic ways in which we're not helping our members optimize that care journey in that pathway, and what would be better ways of kind of surfacing that? And I think what you're getting into now is, I mean, we could go back and kind of cover, I have a few ideas and what I think of as those, where people are kind of falling off the radar. But maybe before that, I guess I'm curious what you think of that from a risk adjustment. I think you could do it based on initial diagnosis. I think one of the things that's, I'll add and interject here, is like, at the end of the day, I don't think anyone knows the right answer, right?
Yeah.
And the goal is not necessarily to quote unquote find the right answer. It's to try and just make better, more educated decisions about what's your members are experiencing. And so I like to test a variety of these. I think different organizations will have their own sort of risk factor that's kind of built up of comorbidities and age and things like that. Sometimes that's a good way to look at it because you're trying to normalize for the kind of risk that a person might have had before they started the care journey. Any of those are basically just proxies for what you're trying to capture, which is, I want similar severity patients to be compared with alternative different pathways that they might have experienced the treatment, and then try and figure out what the right better outcomes I can
Yeah.
buy.
I would say like, the best health plans that we've worked with and engaged with, this is how they approach it. And we'll use Proterra as an example because that's the most relevant. And this is like, okay, this is a program that seems to make a lot of common sense, logical sense. That if you treat someone this way, it's going to be probably more value based than you treat them in a traditional kind of fee for service pathway. And you have that first assessment, they're like, okay, there's probably going to be an impact there. Then you can say, okay, now if there is an impact, now you can say, okay, let's look at people with back pain that went down path A or path B, and then you can see what those differences are, and it'll help. The risk assessment adds flavor and color to the situation. Like, okay, it helps you identify where the biggest bang for the buck is. So let's say it's really sick, complicated people have a huge benefit outsized from simple diagnosis. Okay, that's something good to know. Let's say it's a certain market area where there's like maybe a
And
high,
maybe it's worth pausing on
yeah,
each of those there, because like I'm thinking, like as you're saying, that super sick person, maybe the current kind of providers in the network or in the system are just, those are complicated patients that they have a hard time supporting through their journey. And so maybe I mean, really at the end of the day, this is, healthcare is all done by people, right?
yeah,
So someone is trained and someone is sitting in a facility that's making a decision, and there may be like, might have gaps in how you're treating that type of member. I think you were about to say geography. Again, I think
yeah,
of that
yeah.
as like training and the resources and mentors that someone might have around them. Of, again, the way I think of a doctor in my head is, you've got the lunchroom where doctors will kind of, talk about a difficult patient in case that they're working on. And so, different environments have different ways. And I'll pause again and let you kind of chime in on that.
No, no, we studied this. I think we wrote a commentary on it in Journal of Bone and Joint Surgery when I was a medical student, so 2000, I don't know, a long time ago. But the geography determines your treatment. So if you live in an area with 20 spine surgeons per square mile versus 20 per square 100 miles, your utilization is probably gonna be different, right? And I think that's what you have to kind of factor in. So when we think about some of the risk assessment, like the geography does play in, the natural history plays in. I mean, I think that's how when we work with health plans, we see that process from the med econ side. It's okay, let's look at intervention A, B. B looks like it makes a lot of sense. Now let's stress test where that impact is going to be and in what scenarios it makes the most sense. So, for example, is deploying a chronic MSK program really, really, really high impact for people that are under 30 years old, right? Maybe not,
Yeah.
right? Versus because they're probably going to go online and get their own self-help versus a Medicare Advantage population, which is going to be probably much more high utilizing. I think that's kind of how I think about it, but it's kind of combining a lot of these things together because it is taking something very amorphous and trying to
Because
clarify
now you're
things.
starting to kind of talk about like some of this is I'm kind of thinking about the risk involved with the measurement process here, which is like to your point, participants might be, some are more tech savvy. That person who's busier and younger, if it's not that severe of an issue, like, and this, I can tell you, this is what I've learned from my experience getting injured playing my tag football is sometimes I just need to rest and wait a week. And, what was a really scary moment at the moment that it happened, if you just wait a week, it might get better on its own. Now, not that's I'm not saying that's not.
No,
I'm
but
an
that's the
actuary here,
big thing
but
with
like,
like you see programs that measure surgical intent, right? So if you talk to somebody who has a herniated disc and their leg is having kind of pins and needles and they're having back pain, they're going to think they need surgery, right? But if you wait a week, take some anti-inflammatories, it goes away. And so I think that there is that timing, that certainly plays into it. That's where you get the education and all that stuff, and good clinical care too.
yeah,
When we,
and again, I
yeah,
think you run into differences of like, how educated is this population? How digital savvy are they? The health literacy, all those sort of factors come into play to some degree when you're setting that control group. Not that you have to necessarily, you know, control for each of those variables when you're doing a study, but I think it's helpful to be aware, when you're thinking about things within that context. I mean, I would rattle off like that selection bias is a key thing to think through. And again, you really have to like lay out the alternative care paths and kind of tease it out. I think that if you don't have the right control group, it's very easy to say in a pre-post, kind of get the wrong control group. Regression to the mean is a big risk. I think it's also just really important to think about those other confounding sort of variables. I always am trying to think about things like network changes, benefit plan design changes. If they're changing their prior auth during the period, I think there's times when actuaries don't even know that that's occurring. That can change the
that's
outcomes
a
of the
curveball.
study. And so
Yeah, that. So
so you
somewhat
want to you
related.
want to
Yeah,
gather as much of that
yeah.
information. And again, I'm here we can kind of tease out what might be the best way of doing it. In practice, you're working through these things, but go ahead.
So we think about kind of leading and lagging metrics. Tell me if I'm correct on this. If I think about leading metrics, the first thing we're going to see is clinical improvement from an intervention, right? That's the first thing we're probably going to see, along with maybe some intention, directionality on behavior. Like, hey, listen, maybe this person's saying they need an MRI when they start the program. They don't think they need it at the end of the program. Okay, that's probably going to influence the ability, their desire to get an MRI. Those are the first leading. Then you get into utilization metrics, which would kind of be a medium term. So if you're saying, hey, listen, in a 90 to 60 day 90 to let's say a 6 month window, we're seeing in this cohort the rate of MRI after X-ray or the rate of surgery after initiation of physical therapy, whatever, is different than the other cohort that did not have the intervention. You can then say that's probably going to lead to then cost savings. And from our own cost saving studies, at the very least, you need a 12-month time horizon with a 6 months pre-post, but ideally you get even more beyond that. Is that the
Yeah,
right way to think about how, because we get asked a lot, well, how quickly will we see changes, right? Will we see that this is working, right? Because if it's going to take 10 years, that's going to have less of an appetite than if it would take 10 months. So how do is that a reasonable framework to think about it?
I think it's a good framework. I think there's a few, like, again, the details there can sometimes cause the problems or the extra thinking, which is, you know, how is this program being offered? Is it offered up in a way that is treated as a benefit or as an optional sort of thing? To me, that gets, you have more risk of an open enrollment style like marketing program has more risk from selection bias that again, going back to those things that I'm trying to think through is I want similar acuity members at the time that they're getting care delivered to be able to compare against. And so if there's things in the way that the program's being offered that make it difficult for me to feel like I can compare those two, then all of a sudden you either have to figure out how to adjust your counterfactual to account for that, or you have to think about that. And again, it could go both ways. A program like that could actually be attracting more acute members or less acute. It's not always obvious on the front end what type of members, and it could vary there. But yeah, I think that that's the right framework. And I think the leading indicators are going to be those clinical sort of, is this person seeking, are they still seeking additional care
Mhm.
after starting this care treatment? How does it compare to that control population that we're thinking of? Are they progressing at different rates through the journey? Again, the deeper you can be thoughtful about what your pathway, what your baseline set of pathway. And again, you would group those into a few different, groups of, this is the episodes and here's the way that someone's escalating through that. That gives you better information to say, early on, it's going to take a while for those claims to develop. So I'm seeing good clinical indications. I'm seeing people not seek additional care. Those, I think people think about completion with healthcare. A lot of professional claims actually complete a lot quicker than a surgical claim.
Yep.
And so you actually might start to see those, if the program's working, you're actually seeing a reduction in some of those professional visits that would occur on the front end. That to me starts to signal, again, you're not trying to suppress any care, but that could start to signal that these people are not actually seeking care when they go down this path. And then those more medium to longer term, the surgical, to me 6 months is probably, from after starting care, that's probably a little too early to start seeing surgical savings, or really being able to say that you've deferred or avoided surgical. To me, it's more like probably 12 months to 18 months
Yeah.
from time someone starts that care journey to really feel like you have a better sense. And even then, it might still be too early to see if they're still going to have reoccurring episodes. Someone might get through that. And now I'm actually thinking about, if someone actually has surgery done, what are the chances that they're coming back 2 years later to have another surgery done,
Yeah.
because you got to think about the time frame that you're trying to think about there. But yeah, I think, let me pause there and see what reactions you might have to what I just said. But I'm
No, I
thinking,
think I think that, trying to get some leading indicators on a 6 month time frame, I think is probably kind of the earliest you want to be seeing, or you maybe will get some more than that. We've certainly kind of, written on it. But I think at the very least saying we at least have some directionality by that 3 months after you start a program, you should have some clinical outcomes. 6 months we'll get some directionality. And you may
and
start seeing savings if the program is significant enough.
and again, directionality relative to what you think of as your other alternative, the other care pathways that someone might be
Exactly.
experiencing, right?
Yeah.
So it's really key to have that understanding of what you think the care pathway or care journey that someone else is going through, because that's what drives that counterfactual of me saying, I noticed that in my population, a lot of people are having 15 PT visits, happens to be the number that I require before prior auth for surgery. How quickly are they getting into those into those PT visits? And now, how does that compare to this alternative pathway? In Protera's case, you're offering, and I'll let you speak to what your program does there, but like, you're offering alternative digital virtual care. And, okay, so I'm not seeing the PT visits at the same rate, or I'm not seeing them bundle up around that kind of 15
Yeah, and you
threshold.
also just think about deductibles, right? Deductibles, copays, stuff so you actually have to, counter that there's going to be different utilization patterns uh end of year versus beginning of year, right?
Yeah.
Our department's ortho's a little lighter in the spring and then it picks up later. No, this is great. I have a feeling we're probably gonna do a part two of this because there's more questions that I did not get into.
Yeah.
But I think for a first deep dive into the world of actuarial science, for most people who have never really kind of thought about it, I think this is super helpful. Again, I got a bunch of questions, so we may have to do a part two on this one. But thank you so much, Clem. I really appreciate the time on this.